Good evening, everybody, and welcome to today's episode of Marvelous Medicine. I apologize that last week we didn't have a session without prior intimation, but there were some unavoidable circumstances, both from the speaker side and from my side. So, welcome to today's episode of Marvelous Medicine. The topic, as you know, is protocols and guidelines. Is it the gospel truth? Dr. Ramesh actually wanted to discuss it more like prospects and pitfalls. The anesthesia community does not need any introduction to Dr.S.Ramesh, but because we have people from other specialities as well. Dr.S.Ramesh is a consultant anesthesiologist at Kanchi Kamakoti Child Hospital. He did his MBBS from Tanjore Medical College and MD anesthesiology from PGI Chandigarh. But he always says that his interest in anesthesia was sparked at JIPMER Pondicherry, and he's almost like an alumni to us. He has been working in the first pediatric hospital in the private sector in Chennai for over 30 years, and he's currently the medical director of Kanchi Kamakoti Child Hospital. Dr. Ramesh was one of the first anesthetists in Chennai to commit to exclusive pediatric anesthesia practice way back in 1990, and he was also the first one to start a pediatric critical care unit in India in 1991. From the 90s, Dr. Ramesh has been visiting all the leading children's hospitals in USA, UK, Australia, Switzerland, Hong Kong, and Singapore to keep abreast of recent advances. Dr. Ramesh represents India at the Children of the World Anesthesia Foundation, and he is also a founder member of the All India Difficult Airway Association. Dr. Ramesh has delivered 14 orations and hundreds of lectures across the length and breadth of the country and abroad. I must especially thank him because he agreed to do this talk on extremely short notice, just about 48 hours. Thank you, Dr. Ramesh, for bailing us out at Marvelous Medicine. Moderating the session will be Professor Pankaj Kundra. He is the Dean Academics and a Professor of Anesthesiology and Critical Care at JIPMER Pondicherry. Dr. Kundra did his MBBS and MD from Government Medical College, Jabalpur. He's also MAMS and FIMSA. He's the president-elect of All India Difficult Airway Association. He received the Lifetime Achievement Award from the Indian Society of Anesthesiologists in 2015. He received the K.Y. Bhojraj Award for the Best Review Article in Indian Journal of Anesthesia in 2018-19. He's delivered more than 10 orations and has almost 140 publications or even more, still counting, and several textbook chapters. So he says that his area of interest are airway, critical care, and anesthesia. There is not a single aspect of anesthesia, including basic sciences, in which Dr. Kundra is not an expert and has not delivered some talk or written an article. Thank you, Pankaj, for accepting to moderate the session at such short notice. Co-moderating the session will be Professor Biju Pottakat. He's the Professor Surgical Gastroenterology at JIPMER Pondicherry. He did his MBBS and MS General Surgery from the University of Calicut, Kerala. Dr. Biju did his MCH in Surgical Gastroenterology at the postdoctoral fellowship in hepatobiliary pancreatic surgery at SGPGI Lucknow. After that, he underwent advanced training in liver surgery in Japan, HPP surgery in Washington University, and liver transplant surgery at Singapore. He is instrumental in establishing the liver transplant program at JIPMER. He is the editor-in-chief of the Journal of Nutrition Research and a reviewer in several journals. He has published more than 100 scientific papers and authored several textbook chapters. He has delivered more than 250 lectures at various national and international fora. One of his special interests is nutrition, especially nutrition in the surgical patient. Welcome, Dr. Biju, and thank you also for agreeing to join at such short notice. Over to you, Dr. Ramesh.
Good evening. Actually, Dr. Vidya called me about maybe a couple of days, and I said, can you talk on this protocols and guidelines and pitfalls and this one. I said, okay. because that's my favorite topic. I know what it is about, and I thought I will give a talk. But I gave some talk, this same talk some time ago, but I never gone through again. I said, I let me go through and let me see whether I'll be able to deliver, because the marvelous medicine delegates are something who's who in that particular field. So I felt really, and that to a topic like this, and I thought it may not fit them, but Vidya said, okay, no problem, it should be all right. So after that I went, and then I found who's to put the moderator. I told whatever whoever put, you can put the moderator. I saw both the people, and I got really very shocked, because they're all elite people, and I have to give a talk which is what I feel it. It is not really a very, I can't say very big evidence based, and I just want to tell what I felt about this particular talk. And so with that, I'll just share my screen. Okay, are you able to see the screen? Is it okay?
Yes, Dr. Ramesh.
Okay. See, I did my Tanjore, then I went to Jimmer, Pondicherry, summer 1980, and where I was interested in surgery, but when I went into anesthesia, and I need to know that so much can be done in anesthesia, and it's a really a great branch. Then I switched over to primary branch from anesthesia, from surgery to anesthesia as a non-PG junior resident, and I got my diploma in anesthesia, and I was the first in the waiting list in MD, but I couldn't get it. I was in DA, joined there. After a month, then everybody said that you can go to Chandigarh and write your exams, and then I wrote my exams in Chandigarh and got my MD in Chandigarh, summer 81. In Jibmar, they also, so I had two parties. One is a welcome party to DA, and then send off party to Chandigarh. So it was a really very great, though I stayed for only 6 months, and that is the 6 months whatever I learned is still I am teaching people, and that is the basics which made me to, even now I can't forget all the basic principles in Jibmar. Then I joined Chandigarh and spent some 2 years. I joined as what at that time that's called a second year, because I did 6 months anesthesia, 6 months in surgery. I can join straight to second year. Then I did 2 years in Chandigarh. Then after that I came back to Apollo Chennai, and that I joined as a registrar. I am the first registrar in Apollo Chennai 1983. Then I wanted little money also, so I thought I'll go to Jeddah. There was a interview. I went to Jeddah, and Jeddah actually it's a maternity and children's hospital. In maternity and children's hospital, the surgeon is the first surgeon trained from Chandigarh. So he was very happy a PG has come from Chandigarh, so he was happy on pediatrics. So somehow by default I become the pediatric anesthetist from that time onwards, because though it's obstetrics and pediatrics, I was only mainly into pediatrics. About 90% I did pediatrics in children's hospital. It's a government hospital, but I enjoyed the work. That's why I was interested in pediatrics. So as it went, almost I can say that 15 years is almost, it's more like a training period. Though in Jeddah I was independent, I just I include this as a training period. And 1991 I came back, and that's where the Child Trust Hospital started, and they said, okay, when I met Dr. Appakoti, you join here, he told me you'll grow with this institution, please join, don't go anywhere else, because if you are into pediatric anesthesia. I joined there, and now it's about 31 years. Right now I can tell you I really enjoyed, I learned a lot during my career. And this photograph is a very important photograph to me, and it gives me two things. One is that I am sure we are in Jibmar, we know about Dr. Kangle, and Dr. Kangle is the one who is professor when I joined anesthesia in Jibmar, and I was supposed to give an oration in 2014 and in Mumbai, and having heard that I am going to come and give the oration, she came all the way and listened to my oration. It's a great one, and whenever I go, I used to visit her. Though I spent only 6 months, I think we can't forget the initial guru, that is Dr. Kangle. And second, the slide, what she says is Dr. Kundra is a good friend of mine, so I hope he doesn't contradict all my statements, Dr. Kundra. So I just want to put, so one is important to me, because he's a very, as Dr. Vidya said, he is actually encyclopedia for anesthesia, not only in anesthesia, encyclopedia for everything in the medical field, non-medical field as well. I'm not sure Dr. Vidya remembers this actually. Dr. Vidya, when he came from Jibmor, she joined me as a registrar at that particular. I think I'm not very sure. I joined as a senior registrar, but she came and she was giving the caudal in this was somewhere 1992 or 93, and this is a photograph giving the caudal in a newborn baby, and she was very happy. We spent a good, though it's a short period, we had a lot of very good time. We exchanged a lot of good things, and still remembers, and that made her do a lot of pediatric. Probably 30% of now her practice is in children. So I told, what is the topic you would like to, what is the topic you would like to do? I thought I'll give protocols and guidelines, prospects and pitfalls. But she said, no, Dr. Radhakrishna wants a very catchy title. So I don't know what it was. I told, whatever you want, please do that. So she does protocol guidelines, a gospel truth. Anyway, it has already come in the brochure, so I couldn't say anything to that, but I'm not sure it is a gospel truth, but it is just my view of about protocols and guidelines. It is not probably a gospel truth, but it was really a catchy title. So as far as the history is concerned, as for the guidelines protocol, 1977 in US consensus statements came. In 1989 US guidelines committee is formed. 1983 European countries followed, then followed by Australia, and now in India millions of guidelines are coming into the practice, both in the general practice and specialty and everything. This is an humble disclosure for the people. That this is all about guidelines issues, not the controversies. I just want to tell the important point. It is about the issues, but it is not the controversies. The disclosure 2, usually what I do is I always talk what I do, so I don't have to prepare a lot. I don't read much of journals or books and things like that. For this talk, I almost, when I put it, I have to read so many things because I don't want to say something wrong to the elite crowd. And these are all the articles about some of them I read fully, some of them are only the headlines, and I'm sure some more articles is behind this screen as well. And that's so much I've read, so that I want some points to be told for the take home point to the delegates. So please think in this one, please think critically in this talk whether it makes sense. Don't have to take it that whatever I say is right. Please think critically in this talk whether it makes any sense. I may not be perfectly wise or perfectly correct, but I am going to speak what I feel about this particular protocols and the guidelines. My roadmap for the talk is definition of guidelines and protocol, advantages and disadvantages of guidelines, guidelines and the law, protocols, the universal protocol is checklist, and some conclusions. I think in this particular thing the conclusions will be much more than the introduction and the body. Coming to the definition of guidelines and protocol, it's very difficult. So many definitions have come, but whether it's consensus, guidelines, protocols, algorithm, practice policy are all under a single umbrella, and it's more or less the same. What all it says is that written instruction for the medical personnel to do A in the situation B. So only very little difference between all these guidelines, consensus, algorithms. I'll go to it later in depth in everything, but basically it tells the person to do A in the situation B, and that is what it is going to all the things means. Medical guideline. See, definition of medical guideline is that based on the evidence is medicine, and that gives a consensus statement. It is not really a rule or something like that. The goal of a medical guideline is to standardize, so that everybody thinks what the uniformity in an institution. If you standardize, the quality of the work will be more, and easily you can understand each other. What is a protocol? Protocol is a clinical protocol. Clinical protocol is for the many people, whereas a guideline for a single person. And when you give a protocol, it's a stricter than a guideline, and protocol has got a more weight with the law than the guidelines. What are the areas of guidelines and protocols where it will be of some help to you? Large variations in approach, airway, NPO guidelines, when you want to fast before surgery, airway, whether you want to do video laryngoscopy or you want to direct laryngoscopy, or how much your cricot pressure. So when there are a lot of variations, and the guidelines may be of some help. And large variation in outcome in a trauma, or where you want to give the fluids, you want to go to albumin, and you want the fluid restrictions, and how is the tight glucose control, or sepsis, and these are all the things where it is going to have a helpful in the guidelines and protocol will be of some help. What are the advantages and disadvantages of guidelines? Advantage of guidelines is assisting to practice evidence assessments in individual patients, so that it's whatsoever. Number 2, probably providing uniform standard of care, used as education or a training tool. It may be you like to educate nicely within guidelines, helping patients to make informed decisions by improving some communications. You can tell them these are all the guidelines, this is what we are going to do, something like that. But I feel that disadvantage is much more. See, medicine is not like a cookbook medicine, like a McDonald's. You go to McDonald's in probably in Chicago or Boston or Switzerland or in Gemini Circle in Chennai, wherever you got McDonald's, it will taste the same. Whereas if you want a la carte or a buffet somewhere and different hotels, everything will be little different. So that is what our experience matters. So do you want a cook medicine or you want individual care? So guidelines is like a McDonald's. The second, autonomy of the professional. It is mostly the guidelines, the protocols is imposed by the authorities. The president of the association or somebody, the secretary or the insurance companies is the one which is insisting. It will interfere with the clinical freedom. For example, I have been anesthesia for about 20 years, 22 years. If there is a protocol or a guideline that you have to do like this, do you remember this or do you want to follow this? It is really very, very difficult. The fast evaluation science and outdated guidelines. See, for example, if you have formed a guideline at 2018 and then by the time you make guidelines, then it comes to you, then proof, then by 2020 it comes to guideline, then it goes for another 2 years. In 4 years, there is a lot of evaluation of science and the guidelines may be all outdated. I think it's very important to, if you want a guideline, it has to be updated frequently and see the recent advances. Coming to the how the practice guidelines are evaluated, you can see how long it takes. It takes long time. Identify clinical area where you want to have private practice, best practice, establish an interdisciplinary guideline, establish a guideline and appraisal process, search for and retrieve guidelines, then see whether it's a quality and currency and contents are okay, then adopt the guidelines in the local use whatever you want to do it, then finalize in the local guideline, then official endorsement, then schedule the review and then you have to publish. It takes long time if you really want to get a good guideline. It will take at least 1 year to 1.5 years and then probably it will take another 2 years for the next guideline. By 4 years their science is really evolved. When it says guidelines and protocol, it says or it assumes that one size fits all. For example, the bigger curve is the guideline which is the disease for the disease, whereas the smaller one for each patient. For example, if you take a dengue in a child, if you have a protocol for a dengue in a child, it is for the disease. But in a 1-year-old child, 6-month-old child, dengue with a combination of the leptospirosis, dengue as a incidence with another disease, it will not fit. So the guidelines protocol is for the disease, but it is not for individual patients. As you are aware that in biology, variety is the rule, not the exception. Many guidelines are based on expert opinions and consensus. I am sure everyone will aware of this. So, beautiful article in the Lancet, nonsense and consensus, but what it tells you at the end of the conclusion of this particular article is that consensus is never a part of scientific method, ideal for resolving political discordance. Coming to this particular one, I am sure most of you will be aware of a difficult airway guidelines. The difficult airway guidelines comes in different parts of the world, not only different parts of the world, different within the country there is a different protocols. So there are so many guidelines, European guidelines, you can Scandinavian guidelines, you can Switzerland guidelines, American guidelines, even Indian guidelines. So many things, and pediatric guidelines, neonatal guidelines, adult guidelines. So many things has come into this, the anticipated difficult airway. There are so many things it's come because none is really foolproof. So what is so much? That means it's all multiple things are involved in making guideline. So there is some from Japan or current guidelines about difficult airway were truly useful. What factors should be included to new guidelines? Very nice article which is written, but what he says is all the article, the difficult airway guidelines, I am sure Pankaj Kundra will know because he is one of the part of the difficult airway guidelines. The cause of difficult airway intubation into ventilation are numerous, not single one. Difficult mask ventilation occurs without apparent reason. Difficult airway management in itself may produce airway obstruction. So a lot of things are not really included in that. So it is really, we must think whether it is quite okay in a normal setup. Coming to the second one, I am sure that everyone will understand what is called the fasting guidelines. That is, we have been used to different timing of fasting, how long you have to fast, things are changing, and so many fasting guidelines. You got practice guidelines by the American Society, European Society, even Indian Society of Anesthesia and Indian Association of Pediatric Anesthesia and Scandinavian, all these things given different sort of guidelines. What does it say? You know, because of the Mental syndrome, it has been told that 8 hours solid, 6 hours milk and 4 hours liquid. I think this is what the initial fasting guidelines before surgery. Then they said aspiration is not very common, so they took 6, 4, 2, 6 solid, 4 for milk and 2 for clear fluids. Then the pediatric anesthetists have told 6, 4, 1 is okay. Then some people say 6, 3, 1. Probably in Sweden, by Fricom he said 6 hours solid, 4 hours milk and 0 hours. That means it is called as on demand fasting. That is, if they can allow to take clear fluids, still we say to stop it and you call for the patient. Actually that's because they say that when you stop working, call the patient coming into the induction room, and it takes about 45 minutes to 1 hour, so you can still follow what is called on demand fasting. I think it's very good, but all this thing doesn't include the experience. I'll give you a small example right now. It tells you all the same because that in Sweden they say 640. If you follow 640, if you are not experienced to hold the mask or intubate as quickly as possible, you might into trouble. It's about one month ago I had a small problem which I am going to show you right now. This is how you have to hold the mask. One of the fellow, he has taken about 2 hours of some milk, and he said okay we can do that with all the things. He is not only taken one apple juice something, he is not very sure. It's one incision drainage, and when you put just hold the mask, you can see what has happened. Because if someone not able to hold the mask, you will be in trouble. So coming into the experience of this, that's a beautiful article, beautiful quote. Unfortunately, experience can neither be taught nor studied, but is acquired with the passage of years. Since it cannot be written down, the guidelines almost ignore it. So this actually the shortcomings of clinical practice guidelines. This is a beautiful chapter, very nicely written in the cardiology. This is what is important. The clinical experience, wisdom is the base. and some is supported by the knowledge and pathophysiology, and the guidelines only forms the part of your career that forms a clinician. When you want to develop the practice guidelines, you need RCT and other studies. What RCT tells you, you form some hypothesis. With that hypothesis, we have a clinical study, and then we form all RCTs not really a very good RCT studies. Then we have a guideline committee which is an expert opinion, maybe with all parts of the country, about maybe 8 or 10 people join together, and who are all probably professors and head of the department. And I was also in the committee. We are all quite busy. We don't only do only the airway guidelines, we have got so many other things to do, and then guidelines is formed, and whether we are going to have it in clinical practice, how useful it is. It's going to be really very you must think before you do that. What are the practice guidelines? How strong is the information? The level of evidence is only 11%. A is only 11% in all the guidelines. Level of C is expert opinion is more than 50%, level C. So guidelines and clinical judgment, guidelines are not infallible. They do not fit every clinical situation. Everything is different. They should not substitute for clinical judgment. Beautiful words. What are the overview of the problems? There may be conflicts of interest. One person wants procedural LMA, some other things, so there will be conflicts of interest. Some will DexMed, some will like ketamine. Limited panel composition. Too many guidelines within the country, outside the country, in the world. Focus on too many issues. You must focus on the local issues. I think that will be okay. Again, I want to tell you, it tells that one size fits all. It is not the same. It's only for the disease, but it is not for individual patient. Please remember, the expert opinion it's not equal to or same as a guideline. Expert opinion is not same as a guideline. So having said that, what are the guidelines and the law? We are thinking that if you follow guideline, law will protect you. It is not. So coming to the guidelines and the law, I went through the law in different parts of the world. I will just point some of the things which is very important. Do guidelines have legal implications? This is from Archives of this is of Childhood in 2002. Very beautiful article. It says, doctors should not be lulled into a sense of false security by having clinical guidelines. Medical practice on autopilot should never take place in the law's view. The professional autonomy of the practitioner always remains. So it's important that the professional autonomy experience is very important. There is another one by British Medical Journal, the legal and political consideration of clinical practice. In guidelines, very nicely it's written. And important things, number one, if clinicians implement faulty guidelines, it is they rather than the authors of such guidelines who are likely to increase the liability in negligence. The second, the guideline should not be introduced to a court by an expert witness as evidence of accepted and customary standards of care, but they cannot be introduced as substitute for expert testimony. Courts are unlikely to adopt standards of care advocated in clinical guidelines as legal gold standards. This is another one regarding the NICE guideline. I felt of all the guidelines, see, I'm sure people in UK and who have been in UK, they know how difficult, how important is the NICE guidelines. I think of all the guidelines, one of the best guidelines, taken all the trouble with according to all the rules and regulations, is the NICE guidelines. Even NICE guidelines, there's a question, it's a beautiful article, legal consideration of clinical guidelines, will NICE make a difference? The conclusion of this particular is that guidelines from NICE are likely to emerge a reasonable body of opinion for the purpose of litigation, and medical practitioners who deviate from them should be ready to explain why they have done so. NICE guideline you must follow. If you deviate from the NICE guideline, even in the court of law, if you reason it out why you deviated from them, you will still be protected. So in law, therefore it is expert medical evidence that primarily assists the court in determining what the standard of care should be, and until now clinical guidelines have played a subsidiary role. There is one, I am sure this is a famous in Lowry case in US, that is non-adherence to established guideline does not necessarily bode an adverse outcome for the defendant. This one is ACS guidelines is actually when you were resuscitating and he has arbitrarily deviated, instead of adrenaline when he has given atropine 3 times and he couldn't resuscitate, and there was a law against him. But in the court of law, at the end of it, the verdict is that the defendant physician argued that guidelines were not mandatory and therefore could be overridden by clinical judgment in an individual case. He told me, in that particular case I felt atropine will be more useful than adrenaline, so I have given it. And so the appeal court can affirm that the judgment in the favor of the defendant did not guidelines as being more persuasive than the facts of case itself. So what are NICE guidelines? I am saying NICE clinical guidelines are fantastic guidelines, broad guidance covering management of a particular condition like an hypertension and things like that, and putting a central line, considers clinical and cost effectiveness and patient care and perspective. It's a beautiful committee, they go every step, and then the guidelines come into the practice. It incorporates other relevant NICE guidance like technology, appraisal of specific drugs. Even that conclusion, recommendations are advisory but not mandatory, but can be used to develop quality standard. I think this is what even the NICE guidelines say. It doesn't mean that blindly follow NICE guidelines you will be protected by the law. Can we trust strong recommendations based on low quality evidence? I think that's not possible. I think we'll have a strong recommendations with a high quality of evidence. I think that's where the guidelines or protocol will be really very effective, where you can follow. So what is this one? Abandoning consensus based guidelines is likely to facilitate this goal. I read a beautiful one in one of the articles that clinical guidelines are guidelines and not railway lines. So if a clinical science says like this, you don't have to go like that, like a railway line. You can always deviate, and then for the clinical condition, for that particular patient, you can do what is right for that particular patient. Okay, I have defined guidelines protocol. I defined the advantage and disadvantage of guidelines, and guidelines and the law. Some of the things I have already enlisted. I will just come to the protocols. This is a beautiful cartoon. I could get it. That how far did you get it? He says, I have got the conclusions, I just have to write the protocol. So you get the conclusions and the protocol comes after that. So when is protocol a good idea? It should be simple, inherently simple. You should explicit knowledge, and it should have minimal variability. You can't be without variability, but it should be minimal variability. When a protocol is not a good idea, very too complex, so many things, so many factors, and it is not a good. If you give a protocol, it involves a judgment, that means a protocol is not a good idea. I think you should not actually underestimate wisdom when you want to write a protocol. So there are 4 combinations: good protocol, poor adherence, no desired effect, no point. Bad protocol, good adherence, no desired effect, no point. Bad protocol, poor adherence, no desired effect, definitely not. The best is good protocol, good adherence, and you have a desired effect is a good protocol. So having written that, does the protocol work? Translating guidelines into a protocol is problematic. You will write the guidelines, but guidelines only that you have to transfer into a protocol, and that is a problematic. So when does the protocol is good? Good in some settings, definitely protocol. For example, ECMO during COVID. We don't know, as a person who is non-cardiac, we have not done an ECMO, and they all say actually we can show a partial ECMO, we can do ECMO, and so many things happen, but we don't know at that time definitely when to use protocol, when to use ECMO, when you can stop. I think we don't know the result, so ECMO was very useful at that particular time. During the COVID, no one knows what is happening everywhere, so we all rely on the protocol. but in a well staffed experienced ICU. I am sure senior people are around, hope they agree with me, and operation theatre overall the net impact probably the guideline and protocol is nil. I will give you one example. If you see in the net, there is a protocol how to use the flute. So you have a flute, when you are using it, you actually lip has to be a little low, and then you add a medium, and then don't open lip nicely, and then you blow slowly, then all this thing is guidelines and protocol is given. But whatever you read, you cannot become like a flute, like Saurashya, you cannot make a flute, cannot be done. It is actually done by him, then only the flute can be there. Whatever you read, it cannot be okay. So finally you have a question. Do the protocols work in the acute setting? This is a child which came with 6 months old baby coming for a small surgery on the foot. So I induced the child. I am sure, I hope the non-anesthesiology agree. I am sure they will understand. See, this is a child which has induced. After induction, I am not able to hold the mask. Child is really struggling and the saturation is going. At this particular time, can I think of a guideline or a protocol what I should do at that particular time? I have to react quickly and I need to save the baby. So acute setting, I think it's little bit of a doubtful of guidelines. And this article has been referred by many people, that is protocols in hospital mortality in critical patients. The United States Critical Injury Trials Group, very nicely they have written 6,100 patients in 559 ICU. They classified in 19 protocols, 19 ICU, 19 protocols in ICU less than 19 and more than 19. I am not sure why they chose 19 as the one, but that is what they chose. When it compared both low number of protocols and high number of protocols, it does not mean that if we have a high number of protocols the compliance is high. No, the compliance is the same whether high or low. And your mortality, the day of stay and hospital length of stay and withdrawal support, more or less the same in both the groups. So they do not help. I have protocols. Why do you need a closed circuit? I have protocols. So why I need a closed circuit? There seems to be a statement from somebody who don't like critical care, but we like critical care. The physician strength ICU is very, very important. In ICUs, also in the operating room, with high physician strength, protocols may not have incremental value. If you have very few nurses, if you have few doctors who are qualified, I am sure guidelines or protocol will be a lot of value. Okay, coming close to almost about the final ones is alignment matters. That is lining the right tools for the right job. So misalignment in protocols. If you have basic training, a hospital which is a primary care, BCLS, simpler cares, the solutions for all these things protocol is to be a simpler protocol. If you have protocol in the advanced training, fellowship, extended with tertiary care, quaternary care, then you need what is here it is a CVP protocols like that for a shock, whereas in this advanced one you have cardiac index and then cardiac output. All these things should be done in this. I think different problems needs different solutions, one cannot mix with each other. So what is misalignment? Sophisticated your protocol, it might be useful in the rudimentary. Example, this is, I am sure that all of them, this particular New England medicine, mortality after fluid balance in Africa after severe infection. What is said is initially they said you must have a lot of bolus for the sepsis and they all survive. But what is happening in the other part, in the England, British one, where same transfer to the African countries, when you give a lot of bolus like albumin or saline, then the mortality is very high. Whereas if no bolus, the mortality less. You cannot really interpret only the Jewish, because in African countries we don't know whether they are qualified, whether they have the ICU care, whether ventilator was available, whether ventilator modes are all okay. So there may be a little bias, but this article says that bolus usual for developing countries, not usual for sub-Saharan Africa. So the rudimentary may not be useful in sophisticated. For example, if you have a CVP and that you do as a protocol, it may not be useful in a sophisticated cardiac index and in this one. If you have sophisticated A, if you have probably in Malhar Hospital, may not be same as at a Rayla Institute of Medical Sciences. So if you have a tight sugar control is followed in one, other they say they may not be tight sugar control, lot of controversy in critical care. So it depends upon the actually the level of the hospital and the individual institution. Protocols are very useful. Coming to the universal protocols and checklist. Actually, this universal protocol, safe list by Atul Gawande, is said for preventing wrong site, wrong procedure, and wrong person surgery guidance for healthcare professionals. Why this came is because to prevent never events. Can we prevent never events? It is almost impossible to prevent never events. I'll tell you why. See, for example, this is a child, they put that this child is left sided hernia, and instead of putting a right, they put a tick mark. The tick mark shows that whether you take it as this side or you take it as not this side. This is actually, if you put a non-permanent marker, you put, and then this is the side and the right side, and they start painting it. Once that paints, then the side marks goes. So after that you got a confusion. That particular time the surgeon is not there, only the assistant will do all these things. Still all this one may not be very useful. You must be still careful, you should be very careful. So this is actually Introduction to Surgical Safe List by Ontario. They compared 3 months period under one hospital for almost one is about 100,000 surgeries in each hospital, and one followed the protocol, the other one not, and they found that whether they adjusted as a surgical complications, everything is more or less the same, about 3.2 to 3.6 in both the groups. So if you see the timeout, there are so many things before induction anesthesia, before skin incision, before everybody will be always talking about it. Yeah, if you see really when you are doing it, they usually skip it, they form some joke, and the surgeon may not be there, or anesthetist only will be there, and what they don't know, is there okay, something like that. I think this is what the really happening. I'm sure in some other hospitals very good, but I feel this is what's happening. So it's important, the last sentence it's written, the checklist is not introduced to comprehensive. Additions and modification to fit local practice are encouraged. You can modify simple things so that for you is hospital. So if you want to time out, you can say the immediate members of procedure has to be team, the surgeon, anesthesia. Even in my hospital, everyone say, oh, you start. An assistant will come, you start, put epidural, everything, the surgeon will come 15 minutes. So circulating nurse, we may not get it. The operating room technician may not be there. So it's everyone should be participate. It is not really able to do that. During the timeout, all activities should be suspended. It doesn't happen. They bring the microscope, they shout, and the baby will cry, and it's really very. If you want to have an additional procedure in the middle of the surgery, you should have an additional timeout. That has to be done. It's important, the timeout process must be standardized every institution. I'll give a small example. If you want to do an orthopedic procedure, you don't do everything. Just see whether the correct position, correct side, you have the correct patient, and the correct position what you have to do, if the implants are available, at the end of it, entire team should be present, after that they can go. Simple card, you can just keep it and just see depending upon that particular surgery or particular institution. Okay. I've talked about all this I just want about conclusions. The conclusions are many, please be patient. Conclusion 1, guidelines a great idea, but in all cases opinions that convert data into recommendations require subjective judgments. Since these judgments are a human endeavor, they naturally leave room for error and bias. Conclusion 2, clinical guidelines and protocols are yet to show benefits and clinically relevant outcomes, but can raise standards of care, no doubt. When basal quality is low, baseline education is inadequate, outdated, it is very useful. And implementation, traditionally low compliance, requires a focus on staff education. Sustainability is a tedious process. Even my own hospital, when the timeout came, we were all very tedious talk, but slowly it has come down and we are not as efficient as it was started before. Conclusion 3. Good guidelines is summary of evidence-based medicine. It is the exploitation of implicit knowledge. Guidelines is the basis for the protocols. It's the technical schools, and sometimes guidelines as basis for a benchmarking. Today, more than ever, there is a need for physicians to be trained not in guidelines but in basic pathophysiological and clinical management. Starting from undergraduate. Why starting from undergraduate? You start from the school, from the +1, +2. They are not bothered in doing depth of this one. They just memorize because they have to get 99.99. If you get 99.97, you may not get the seat. So I think this has been started not from the undergraduate, it has started basically from the school to memorize. People from 6th standard and 7th standard, they go into IIT course and so much course, they just started memorization. So starting from undergraduate level, the student of medicine should be coached in judgment and not on memorization. So memorization is passive while judgment is active. Why textbooks? Why in depth? Why not immediate? So it's a book written by Merin Wolf. The gist of this one, that we are not only what we read, but we are how we read. I think that's very good. So the process of in-depth reading shapes the mind. People don't read in depth. You can ask anyone, even in anesthesia I know, they don't read any textbooks. They don't go into everything. At least I tell them, please have one textbook, read from top to bottom. The remaining you can go to Google, internet and all these things, notes. But no, I can tell you, vouch, no one reads textbooks from top to bottom nowadays. Having said that, this is the final conclusion. Science is built up of facts as a house is built up of stones. But an accumulation of facts is no more a science than a heap of stones in a house. Thank you very much. I hope it is not, I just want to again I come to, there are people who are senior people who are part of guidelines, protocol. It is not against anybody, it's not against the protocol. This is just the view, but if you want to have a guidelines or protocol, you should be done properly and should be adherence and the compliance, and it should have a good outcome, and that is more important. Not, I am not against, but I just told the view. Please do not take it very seriously. Thank you very much.
Thanks a lot, Dr. Ramesh. It was, as usual, a fantastic lecture, and I enjoyed every bit of it, every statement you made. Okay, let me put across one question. You are a part of guidelines group. One of the guidelines, and you are probably...
Yeah.
Right? So what's your opinion? When you formed the guidelines, did it take too long? Do you think they are robust enough to be followed? In majority of the cases, what's your opinion about the guidelines which you have developed?
Pankaj, this is my own, don't put me into trouble.
No, not at all.
No, it is nothing.
This is be frank and open. It's
no. This is just I'm just. It should not be biased, and I don't have. I'm just thinking. It's individual variations always differ, but see, what I feel is that for example, this is All India Difficult. This is one guideline. I got the guideline by default, not exactly because I am a, but that's okay. But I enjoyed all this thing. But if you see, everyone should have that sort of people who are involved in that, not by the, I feel that's what I was telling. The person who having a guideline should have worked in that particular field, and this not because of their hierarchy. You see, that's what I just want. People who are in guideline, you want to develop a guideline, should be hierarchy. I think we took little time, not bad. I think it's about 6 to 7 months we had to do the first guideline. Then it came to probably 2016, if I am not wrong, and all the guidelines each were given group and all these things. And then I found the compliance for this guidelines is good in the institutions, but it is not going to the individual practice. This is good in the institutions, but it has not gone into the individual practice. But I felt that has to be you go into the individual practice in a small places, then only the guidelines protocol will be of some help, and the compliance will be a little more better. And 2016, now it's 4 years, probably the COVID we couldn't do that. I think it took little time for the second guidelines. Already we are forming the team and all this, I am sure, but I think this is slightly long, but I can't blame it, because it is the because of the COVID 2.5 years we couldn't do anything. I think it is starting another time on. This is the first time we are doing it. We cannot be perfect, so I think we should be able to do better now.
Thank you, Dr. Ramesh. I totally agree with you. Absolutely right. Whatever you have talked about, there cannot be any, any two thoughts about it. One of my opinions would be that when you form guidelines, especially for the trainees or the postgraduates who work with us, you are compartmentalizing them to an extent that they are not able to exercise their mind and think out of the box. They just have to follow the protocol, because probably the patient safety is more defined in such protocols and they are not supposed to violate. And most of the time they are working independently, so we need to care about the patient safety. But the problem is that they become so fixed to those ideas that they don't think beyond that. And that is where innovation is lost. Because even if they think of it, I think a lot of people would not appreciate the ideas which are coming from them, because the guidelines don't permit it. So that is where the problems I feel I have seen, that the out of the box thinking and the way they want to put some innovations to see how things work, we are probably killing those ideas. Thank you. I think Dr. Biju is there. He may also would like to add some comments.
Thanks for the wonderful talk, and I think a lot of points to learn. As you said correctly, many of the higher institutions which generate knowledge should not follow guidelines strictly. What we call, at least in our department, we call some patients are protocol victims. So you have a set protocols, and because of that, some patients really suffer. We see in various published literature also, and across the world this happens. So as Dr. Kundra told, generate the patient-based education rather than protocol-based education and teaching. That's the importance of this talk, I feel. If you keep on teaching the protocols, guidelines, standard operating procedure, checklist, what happens, the innovation and the thoughts of the trainees will be totally lost. They will not learn from patients. Learn from textbooks and guidelines, and they think that that is the truth, which is not the truth that what we know. This is what I wanted to say. Thank you very much.
I'll give you a small example, sir. To be frank with you, I get a call from some part of the country. Dr. Ramesh, do you have any guideline or protocol for anesthesia for cleft lip and palate? So just thinking, can I have a guideline for anesthesia for a lip and a palate? I think it is I didn't say anything, but I just thought that is the situation of the people who are thinking, how can you have a guideline for anesthesia for lip or palate? There is, you know, under variabilities, and we cannot say that this is how you use it. It's as long as there are many ways of killing the rats. If whatever you use it, please kill the rat. That's it. So I think that's how we are to do it. But I think people have understood. I am not really what I am also part of guideline. I like to know about the guidelines. I think it's instead of institution, I feel it is more important for the people who are using in a private practice and other places where they have some doubts, they can always do that. Institutions, we have always have a guideline to, we have people to help you out. So it is not, I'm not telling that this is because the talk was given to me for someone, so I have to prepare, I did it, but it is not exactly the what I'm thinking. I'm not against a guideline, I'm not against all this thing, but if you have to do it, you have to do really properly, and then just because 4 people join and get a consensus and this is the guideline, I think that's a little not only in our country, it's happening all over the world. It is not that is except the nice guidelines, probably the one of the topmost guidelines, we take all the trouble to do that, but other parts are not really very okay. That's why I think nice guidelines are very good. Pankaj, any idea about the other guidelines? I think I found nice is taken a lot of trouble to do that. That's what I am telling. It should be done properly, then everything is okay.
As far as they are evidence based, it is perfectly fine, because there will be a lot of science into what comes out and what has been written there. But I do agree that consensus guidelines and others don't make much of sense, but there are excerpts in them also which you can pick up, which are words of wisdom, which would generally tell you, yes, you have been doing the same thing which they are trying to tell us, though the evidence may not have been there. So it's all up to us how we pick up things. And as you rightly said, that treatment or management of patients cannot be protocolized. It has to be customized. So you have to customize the dose, the drug for each part, I mean the therapy for each patient. You can't say that it is a general rule for all. When you go to a tailor, you just don't give a single, you don't give a single size. You want it to fit to yourself. You want it to fit to your structure. And I think that is how medicine is, that you need to customize treatment. You need to customize your management, not generalize what is happening. That's what my opinion would be, sir.
I am very happy Pankaj Kundra also agrees with me. I thought he will fight with me, but it's okay. But that's okay. I think that's what he was very clear. You should individualize and see that particular situation. Acute setting, it is very well. That one thing in acute setting, it's very, very difficult. But in a probably in a, see, it's a protocol is very good. For example, oncology patients, it's really very useful. You know, it's a chronic patient. You know, this is a chemotherapy for 1 month. So those types are guideline protocols will be really very useful. In a ICU setting and acute setting and other things, it may be little it may help. I don't know how far it will help in acute setting.
Yes, sir. It shows your way, it shows your path, but you have to walk the path. How you walk it, whether you drive, whether you walk, whether you take a bicycle, it depends upon you. It just is a path which is given to you, that you follow this and you will reach the destination. I mean, to a small just a synopsis of it, what guidelines tell you, that's all about it. And there are a lot of variabilities which are added on the way, and we need to take them into account whenever we follow the guidelines. It's not, as you rightly said, they're not tram lines, they're just guidelines. Any other questions? I see 1 or 2 questions here in the chat box, sir. I can just put it across. One of the members have said, if you follow standard textbooks teaching, doesn't it suffice? Why talk about guidelines and protocols?
No. I tell you, I am very important in this particular aspect, that standard, I don't think we have any authority to tell about the standard of the textbook. Any textbook is actually, there will be some mistake this way, that way, but if you have a standard textbook, it's almost 90%, because for example, if somebody gives something dexmedetomidine in 2 months baby, 2 months baby, and there come to some problem, and the court of law said you cannot use dexmedetomidine in 2 months old baby, and if he takes a standard textbook and tells the dexmed can be given 2 months, that is evidence to the court. You cannot really do it. So the textbook is really very good. I don't think you must read everything. Only 3 or 4%, maybe any book may be less, one may be more, but I think standard textbooks are the gold standard. You don't have to do one, this is better, that is better. You can use any textbook, and the textbook is the evidence for you in the court of law. I think journal may be also in the court of law, it is very evidence, but I think you must read the textbook. I don't think we can comment upon the standard of the textbook when you are reading it.
Dr. Ramesh, Dr. Bagli was actually saying that if you read a standard textbook, why do you need guidelines and protocols? That was his question.
Oh, I didn't say.
We
Okay.
break our head on guidelines and protocols as long as we stick to textbook. I suppose the answer would be that when you say even guidelines and protocols are difficult to be up to date because it takes so long, the textbooks will probably be 10 years. At the rate at which information is exploding and the new knowledge, that may be the only handicap for going solely by textbook. Would I be right?
Yeah, I think that's fine. Yes, okay. That's why textbooks takes long time, and with the digital now, I think slightly better, but because it's a little more faster. But only in the with the new textbooks with the multiple authors, they just maybe some of them will copy and paste, and the textbooks are coming not exactly from the individual things. So that is all the problems the digital world. But I think a textbook in digital world is slightly faster than it was some years ago.
Dr. Rajesh, were you trying to say something? Rajesh M.
Dr. Vidya?
Yes.
Yes, sir. Dr. Bagni, go ahead, sir.
No, in this litigious society, the things have changed over the years, the way I've been practicing medicine. So I was just wondering, Ramesh was saying.
Dr. Bagni, you are muted. Can you unmute yourself, please?
Yeah. No, I am saying in this litigious society, I thought the guidelines are mainly to help you out in such a situation, because you do your best, but things go wrong, and then the patients get angry with us, and then they try to take us to the court. So that time when we tell we've gone according to the guidelines, we've done everything right, does it help us? Ramesh, what was your point on that? You said still in the.
It will not help, sir. It will not help. It will not help, sir, because
I was thinking guidelines is mainly for that only today, because otherwise, see, I have finished my thing. I know how to do. Mostly, we practice the way our mentors teach us, and that's the way medicine has been learned. See, I learn from you, I teach the others. So where's the question of guidelines? What we have learned, what we practice is what we learn from our seniors, and then this is what we learn from the books. This guidelines and all is something new, which I don't know why it has come in the first place. I was thinking only just to help us in the court of law, these guidelines are there.
No, there's a lot of articles on that, sir, to all these things. The protocols are slightly better, sir, because if you say a protocol, they are slightly better in the law, it has got some value. But if you say the guideline, it is not exactly about guideline is start for about 10-15 people with consensus statements, with some with evidence based. No, but in case if your skill, the patient lost because of because skill is not there, and you have not been there, and guidelines I have followed like this, it is not going to, many of them guidelines is not helping you out, sir. As a guidelines, it is not going to help you, sir.
No, other way around. If you go away from the guidelines and if things go wrong,
that's what, if you go against the guideline and things are go wrong, if you say why you have done that at that particular moment, that will be protected, sir. That is that means that's why the expert opinion scores over the guidelines, sir. If the expert opinion scores over the guideline, because I followed the child is a problem. This is my opinion. I know Pankaj, whatever Pankaj says, I don't know whatever. If you follow guideline and then I see, for example, difficult airway, you follow 3 times, this one, 4th time you take video laryngo, child dies, you will not be protected. I follow the guideline, the child died. That I don't think that will be protected. I know what Pankaj is saying.
Sir,
no.
No, it's a very difficult question to answer, because see, it also depends upon the person who's sitting on the chair of the judicial, how well he's perceived to the problems that we face. I don't want to say anything in the open forum, but there is a lot of variability in what kind of directions come from there. With all due respect, I think it's all the person who sits there to take a decision, whether he uses or he doesn't use the guidelines. I mean, it all depends upon the person sitting there. That is how it is, sir.
Absolutely right. I think we cannot really say that. I think we should increase the law here, one other person here, to see what he is doing it.
Dr. Biju, would you like to add to that?
Yeah, I think in litigations, what I feel generally checked is can prove that I know the guideline, but I deviated positively because of this is a better situation than I'm not at all aware about the guideline, but my deviation end up in deviation of the guideline. So that probably will be a trouble. Okay. For example, we deal with cystectomy related bile duct injuries very often, these sort of RTIs and all that. What really check is the person who deviated the protocol knew why he deviated. That's a very safe situation. Whereas he is not at all aware about such guidelines exist, that would be probably a problematic situation. That's what my opinion is.
This is actually I don't want to. This is I'm not really expert in all these things, but I just realized and then read about it and then put into my perspective. That's it, and it may be right or it may be wrong, and that's why please think and see what is right for you. And it all in the court of, like what Pankaj says, is whatever you say it may be right, but there in the court of law whether the expert is really some in anesthesia, for example, that anesthetist will not be somebody who is orthopedic surgeon will be the expert for you. So I don't think it is we can't say the blanket rule this will protect or this will not protect. On the whole doesn't mean that if you say I follow the guideline the problem solved, you will not be protected, and that is what I am going to. You cannot really fall on the guideline and protocol and then do whatever you want. I think that is cannot happen. That's what this is my feeling, and it is okay to do that.
Ramesh sir, it was a wonderful presentation. Good evening, sir. And
yeah, good evening. Yeah.
And I thought guidelines has got a legal validity in the Indian context. So thank you for the clarification. What about the institutional protocols? Suppose we follow the institutional protocol and some mishap happens. Does the institution is legal bound to protect the individual who follow the protocol, or you can it's sort of a protection in the court of law also? See, I have followed the legal institutional protocol, and I have landed up in trouble.
I'm not really I'm not expert in this particular the law and the judgment, but I feel the institutional protocol, what I feel is that you must see, very important as anesthesiologist anybody, we must be with the institution. I think that's what important is. I think if you do your institutional protocol, the institution will support you. That's what I feel, that institution said whatever Ramesh is okay, and institutional protocol you see. So see, probably if you are an institution, if there is any problem, you are not only involved, your institution is also involved. In case you are against any of the protocol, against the institution, then you will not be protected by the institution, then you have to fight by your own. I think it's important that if your institution and local, that's why if you all the protocol guidelines, if you can do to the institution, I think they are okay with that. But because institution has to protect you during this, because that's also part of your I think very few individually will be really taken to the court. The whole institution will be whatever it is, their precaution responsibility, and institution will be there. So I feel that if your institution, they have a protocol, you can't say I do like this 30 years I'll do the same. It cannot happen. An institution have to be part of that. I am not sure they will protect or not, like what Dr. Pankaj says, it all depends upon the final judge or advocate or the expert, how they are going to do that.
Dr. Ilango Setu, you have your hand up. Please unmute yourself.
Ma'am, I don't have a good bandwidth, so I'm not on video. So what I feel like, this is my opinion, and I would like to hear the opinion of others on this as well. The complexity of medicine is actually increasing day by day. The amount of data we had to digest as students in the 80s and 90s is too small compared to the data which we have accumulated over here. Now at this current point of time, the up-to-date which I was using in 2007-8 was just copied on a couple of CDs. I think it's impossible to do that now. Now they have got guidelines in every small bit. So the voluminous amount of data requires some bit of key to actually handle. That is, I think, one of the reasons why we should follow guidelines. Obviously, they are not the all or none phenomenon. We have to follow everything. It is not going to protect you in the court of law. You're still Every expert is decided by the amount of experience that he has accumulated in gaining that knowledge and handling those problems. So a guidelines cannot be a substitute. But in a place, see, I am a practicing transplant surgeon. When I come to a hospital and when I look at the situation, and I needed a simple method of connecting with the nurses who have never done transplant, or with an assistant surgeon who has not done transplants, or with a nurse practitioner, and I have to simplify the things that are in my mind. So I write them in a way, and I feel that only becomes the protocol. Some of the things make no sense for others. Some years ago, I taught one oncologist about decision making in secondaries in the liver. So I told him a simple method of remembering. I had written it as 23670 protocol criteria. So it is either both the portal veins are involved, all the 3 hepatic veins are involved, more than 6 segments involved, and more than 70% of the liver involved. This is a San Francisco Consensus Conference on colorectal liver metastasis to decide whether neoadjuvant chemotherapy has to be administered. So to do that, I had written a very simple rule called 23670 criteria. Unfortunately, this gentleman went and presented this to one of the senior oncologists and thoroughly got bashed. So this was an institutional protocol for decision making. So I had to explain that. So whenever we read a voluminous amount of data, like how we are accumulating now, it is best to write down the keys so that everybody in the department is in the same page, so that the safety of the medical treatment or surgical treatment is at par with the internationally recommended things. I think in an individual case, it's very difficult. Our standard venous anastomosis kidney is a 50 proline. Everybody picks up a 50 proline, but once in a while, I told them, okay, cancel everything, I need 60. The decision making cannot be done by everyone. The nurse cannot make the decision, nor an assistant surgeon can make the decision. It is done by 1 or 2 people in a department, so that care of the patient proceeds at a standard form, in a standard fashion. That is how I feel protocols must be used. They will never defend us in the court of the law, and whether it is institutional protocols or recommended standard guidelines, they are just a light to the pathway because of the complexity involved. That's my opinion. Thank you.
I totally agree with you. And in fact, that's the same thing which we were talking about. And of course, Dr. Rajesh also asked about the institutional guidelines. I think not very long ago during COVID, all institutions had their guidelines for COVID management. Everyone had their own guidelines. AIMS had its own, JIPMER had its own. So these were guidelines, institutional guidelines, according to the availability, according to the staff which we had, so that number of untrained staff could follow simple path which was there to treat such patients. And even for departments, you have residents who are doing night duties. So in the code of law, many a times, if there is a mishap which occurs, the judiciary always asks you, do you have a protocol, which the residents have to follow? And if you have a protocol written there that this is what they are supposed to follow, and this is what we follow, to a great extent, you are saved. So department protocols, institutional guidelines are more robust rather than the guidelines which are universal in nature, which may not be applicable to all institutions. So that's my opinion. They are more robust because they are standardized to your place of work, to your people, and to your logistics. And if you have those protocols, and if certain things happen even during your absence or when you are not there on duty, you are protected. Thank you.
I think that's what is important. The institutional protocol are very good because it will not whether protocol, but it will be very, very useful for our own department because they know that what you are doing and we know what we are doing. Because probably if you take over at 8 o'clock, another junior resident comes and takes over, and you know that these are the things they could have done it except very few variations. I think institutional protocol very good for the patient care. I am not very sure it will protect, but definitely if you do that, HOD will protect you and the institution will protect you.
Abhay, you have your hand up. Would you like to say something?
Yeah, I'm Dr. Abhay Martin. I'm a practicing dermatologist. I introduced myself as a person who was part of the team which gave the Indian national guidelines for Stevens-Johnson syndrome and toxic epidermal necrolysis. We had a situation which I would like to share with you. There's a very famous case called the Kunal Saha case, wherein his wife actually came down. They were HIV specialists in the US, and they came down here, and his wife developed a rash, and which was not initially recognized. And then subsequently, the patient was put on steroids as an initial management of Stevens Johnson and TEN. And one of the most hefty compensations in the Supreme Court, the case went up to the Supreme Court after the district court and the appellate court. And even the consumer redressal forum actually gave the verdict in favor of the doctors. But unfortunately, the Supreme Court, it is something of a legal matter, but still I would have to say, unfortunately for us doctors, this was a compensation of nearly 11 crores, which is one of the highest compensations known. Now, in this background, what happened was the evidence which was produced was guidelines from other countries. Indian guidelines were not there at all, and there was no Indian data available. Now, in this situation, what happened is steroids being used as the first line treatment in Stevens-Johnson syndrome or TEN was not accepted in other countries. Whereas in India, by clinical experience, we have noticed that either systemic steroids parenterally used early enough are life-saving. But later, as the disease progresses, the risk of sepsis increases. It is difficult for you to start steroids. So here you have a dilemma situation where a guideline had to be given that even the use of a steroids or the use of a cyclosporin would be useful. Now, the situation there was when the court asked for the guidelines or literature, most of the guidelines were produced from outside the country. And the standard protocol there was to have the plastic surgery unit handle the Stevens-Johnson syndrome because they're used to burns units. Now, my contention is that unless we have some guidelines or some Indianized versions, the court of law would always look at what is the current best evidence. That would help us to some extent, at least to standardize care in the Indian setting, because we have a very rich clinical experience. Secondly, some of the guidelines, the second viewpoint is some of the guidelines may be industry driven, because most of these people who sit for guidelines may have a certain set of people who would be setting up these guidelines. And if I might take this particular example, in urticaria, we have a set of guidelines which says that you can escalate the antihistamines by giving 4 times the dose. Now, which as practitioners, we have seen that it is not always the case. You don't have to escalate it 4 times the dose, and we do not know the adverse effects of antihistamines. Now, these are 2 dilemmas which we actually deal with in day-to-day practice. Guidelines will give you sort of a straitjacket, which students tend to learn. They do not think about the outliers. But sometimes in legal practice, when you need to defend a victim, or for that matter, a doctor, I think guidelines have their role to play. And especially Indian guidelines are required in more for more reasons than not. This is a classic example which I was mentioning about, wherein the litigation went up to crores. If there was an Indian guideline, probably that would have saved the day for the doctors who had so sincerely tried to save the patient. These are my 2 words about this particular topic.
That's right. See, in a setup like a clinical setting like dermatology, we have some time to think of it. I'm talking about a little bit of a critical care and acute setting, it's okay. But I think that particular time, I'm not very sure if probably if I don't know, it all like Pankaj said, it all depends upon the judge and who is sitting there and who is the expert opinion. But if somebody gets if that steroid is given, you don't need a guideline to protect you. If textbooks says that steroid be given, that will protect you. You don't need a guide. If there's no guideline, if your dermatology textbook, standard textbook says that, I think this is my says that you have got this one, I think you will be protected. I am not sure whether that was done. It all depends upon the person who is sitting, but you don't need a guideline to protect, but if you have a textbook says something, I think that will protect.
Ramakrishna, you want to come in and say something?
Now, the poll was in favor of no guidelines. I'm upset about it. And I'm also upset that Dr. Ramesh and the learned Dr. Kundra and Biju Patakar, my good friend, were not in favor of guidelines. I'm really, really upset. But then the last two speakers, Ilango and Dr. Abhay, actually gave some solace to me. I think we all look distant because we stand on the shoulders of Jain, so written everything. I think all our postgraduate education is based on protocols and guidelines. What comes in the textbook is what is established. I don't know whether Biju will agree with me. Every damn disease in surgical gastroenterology is based on a certain set of protocol, whether we treat acute infective pancreatic necrosis or a 2 centimeter carcinoma rectum. See, you all three of you as examiners, you will expect students to say all these things. If they do not know, and how can, actually when I joined, when I went from Chennai to Delhi, my boss asked me, what is the commonest cause of upper GI bleeding in Madras Medical College? I did not know because there was no data, as Ilango rightly puts in. Then in Delhi, there is a clear data for everything. If the patient vomits 3 times in the night, you have to put a Riles tube. The sutures have to be taken in this particular manner. I think there should be a certain way of teaching this, and that is all come from these guidelines are not written just like that, sir, because if you see the work, NICE guidelines. I was in 2006, I was in Edinburgh when the NICE guidelines for G-junction tumors were written. I was in a meeting where actually a lot of deliberation, lot of literature search, and done in very scientific manner. Good that you kept on pointing to NICE guidelines. But it matter any legal issue, anything, the lawyers want reference of articles, reference of textbooks, all that. What do they know about medicine? And actually, all these are written based on guidelines. I think the younger generation shouldn't go back home saying, no, we needn't bother about guidelines. I mean, you're all senior people, you are experienced, and your specialty of anesthesia is something where you make very quick decisions. You may not think of guidelines, but you'll ask your junior, when do you intubate? What should be the PO2? What should be this? What is the criteria? When do you dialyze a patient? What should be the creatinine? And there are set guidelines that's what you follow. I mean, I do agree with Dr. Abhay, and no, I'll agree with the fact that a lot of guidelines cannot be followed in India. For that matter, every G junction tumor need a PET CT scan. How can you do it in India? That's an NCCN guideline. Now, all Indian associations, local associations are trying to make their own guidelines depending upon what is available and what is feasible. I think that is the way forward. Guidelines can't be thrown away. Indian guidelines are necessary. Vidya.
I think Vidya, you should have put a pro-con session, and pro must have been Radhakrishna and me should have been con. Then we would have come to some conclusion, and then it's okay. See, please remember to everybody, I am not demoralizing people. I am not telling please don't follow the guidelines. I don't follow. See, if you want to form a guideline, please do it properly and do that and do it. It is not that if you, that's why everybody should think properly, and this is what this is an elite crowd. If you are going to, I am going to teach a postgraduate, I am not to tell you please don't give a guideline, please follow what I say. It cannot help. PGs I take in different way. The delegates for marvelous medicine are all learned people who are top in the people. I just people will think, just a point of discussion to people, think what is it, just a pinch of salt, whether right or wrong. So this is my opinion. I have never told the guidelines and protocols should be thrown off. It has to be followed if it is properly done, and it is to be taken which is right for you. Do it for the institution what is right for the institution, but don't follow the guideline protocol tells you have done. There is a difference between a little bit of, not that it's okay, what you are talking about, gastrology, dermatology, oncology are very good because you know that this has to be done. In anesthesia, critical care slightly little different in acute setting. So I think there's a difference between acute setting and wherein see, for example, the beautiful the protocol for a Wilms tumor, fantastic. You have to do according to that. If you miss that protocol, you will be in trouble. That's because you have Wilms tumor, second stage, you know what has to be done, that has to be done. That I'm not telling it's completely wrong. Please to take which is right, whether it is done in chronic cases, clinical cases, it's all okay. In acute cases, some other thing you must think whether it's okay. And so you cannot take blindly this guideline protocol, please follow, you got in trouble, then you said you cannot do like that. That's what I was telling. I think it is not that I am against guideline. I am actually for tomorrow I am going for a guideline meeting allowing Pankaj Kundra to airway guideline second time. So it is it is not really is okay. The topic was given to me, I have to talk 40 minutes, so I talked what I liked it. That's it.
If I can just put in my 2 cents, I think when you're doing something you have never done before or not done enough, the guideline comes to your rescue, because in our country we don't have a situation where every treatment is done only in certain specialized centers, and the privileging and credentialing is not that strict. So I think the guidelines, like Dr. Pankaj and everyone mentioned, it gives you a roadmap. Like the example you took, like COVID was for others. Many things may be first time or not enough experience for other people, and in that situation I think guidelines come in very handy. And guidelines help you to make your own institutional protocol, because especially when you say there are so many guidelines from different parts of the country and the world, then once you go through them, you know what bits and pieces to take to make your own protocol. So when trying to provide uniformity of care, I think protocols and guidelines do help us a lot. But I heard, from some of my friends practicing in US, that in fact they started reducing the number of protocols which they used to have in ER and other places, because any deviation from protocol was being used for litigation. So, so it will be like a no-brainer. Actually, that didn't make any difference to the outcome, and the clinical judgment was correct. But still, if there is 1, 2, 3, 4, 5, like how when you do a BLS program and you do the post thing test, you cannot write sequence 1, 3, 4, 5, 2. So almost everything happens simultaneously. If you don't write in the correct sequence 1, 2, 3, 4, 5, you get a wrong mark. Something like that is what was happening, that even when it did not contribute to any the adverse outcome, any deviation from protocol was being used by the lawyers to, so some of the things which were protocols, they actually changed to guidelines, because guidelines gives you the way to sort of create or change according to. Since we have 3 of you teachers here and many more, I suppose, how do you, Pankaj, Vidya and Ramesh, one last word as to how do you think we can continue to have guidelines and protocols during the education phase of the students, but at the same time empower them and sort of, what should I say, inspire them or them to make their own proper clinical judgments once they move out of the protected phase of their life?
Dr. Pankaj and Biju will really tell you, because it is true, but my feel is that I think they can do. I feel it should not be too many. It should be a simple 4 points, whatever the way. I think simple should not be very complex. I think it should be as much simple, and it should be followed. You should be able to follow in a local setting. See, most of the guidelines and protocols will be able to follow in a tertiary care center, which may not be very possible in lower settings probably. And India is a very inequality, where we are still using a boil machine which is Mark III, which is almost thrown out. So I think setting giving a protocol and say you follow it may not be uniform all over the country. I think it has to be institutionalized, it should be simple, it should be very concise. I think that should be okay, it should be practical, and that should save the child, or the outcome should be better. I think that's what it is. I am not part of any of the psychology research. I am sure Pankaj or Dr. Biju will definitely put some words into that. Pankaj?
Okay. I too feel that yes, during the initial period of training, at least the first 2 years, they need to follow guidelines because they are under supervision. At times, they need to know how things have to be done in a right manner. So we do have our protocols, our institutional guidelines also, and those department protocols help to teach them to do the things right way. Like you have the machine check protocol. It has to be followed by them because that's a safety measure and that safety has to be done. I mean, that safety protocol has to be done. If there is a WHO checklist, it needs to be done. Everyone needs to be educated about it. And the problem is, yes, people flout the checklist. They don't listen, they don't talk, and sometimes they ignore. But we need to enforce certain things because all of them are meant for better patient safety. But at the end, it is also important for us to emphasize that these guidelines are telling you a path to follow. Now that you have followed a path, you know there are certain ways you can do differently. You should be allowed the liberty to do them differently and then probably have scientific approach by developing a research project or a conceptual idea, which can have a scientific evidence later on to prove that these things are better. So things are evolving, guidelines are evolving, and we are evolving with them. So all of us have to guidelines, protocols, our experience, medicine has to evolve simultaneously. It cannot be treated isolated. Thank you.
Your on this.
Your mic is muted, Dr. Biju.
Yeah, I think the guidelines are best suited when the environment which mandate a task in which multiple people of different expertise is available. For example, you have faculty or residents, you have nurses, and technician, then you need a guideline. But at the same time, you have 10 similar experienced faculty sitting together and making, talking about guidelines in between them to follow. It makes no sense. That is one. Our experience of, I was incidentally editor of the patient safety framework for JIPMER, which runs into more than 500 pages. So what we did was, when you have a very best evidence, we put a checklist. You have a further a little bit less than that, we made it a standard operating procedure, but evidence or conviction is less, then we made it as a guideline. So we have to understand that, let us say the WHO checklist, everybody should follow because the evidence is very strong. That's why it is a checklist. At the same time, when you do a surgery, you use 5-0-proline, 6-0-proline and all that. That cannot be part of a neither standard operating procedure nor part of a checklist. It can be simply a guideline. So guideline is not the best framework we work in the medical field. We are more, if you have more evidence, you have to make it a standard operating procedure. Furthermore, you can incorporate as a checklist and more. So we have to understand this similar limitation. At the same time, in complex environments, multiple expertise people work together for a single task. These guidelines and standard operating procedure and checklist will really help us. We also follow that. That's what my opinion.
Thank you very much for, sorry.
Only request I want to tell Vidya, this I didn't know this is so much of controversy. Please do not put in the YouTube. Radhakrishnan will kill me, see. So I don't want to put in the YouTube. This is for marvelous medicine. I give a talk, but don't put the YouTube putting me into trouble. That's a humble request I'm going to. I think I should have put as a disclosure from the beginning itself that you should not put that. That's okay. I don't mind. This is just opinion. Okay.
Lata, you wanted to say something?
No, just wanted to say about same thing about what Dr. Ramesh was saying. I think, sir, you should not be worried that what will happen in YouTube. 50% of the people will be going with your thoughts. The other 50 maybe with going with the guidelines. So even in JIPMA, everything cannot be followed minute to minute. Broad guidelines are fine. But as Biju was saying, whether you use 5060 cannot be written in a protocol. It is like local needs, local availability, and so many things. So broad guidelines are okay to save us. So I mean, it has to evolve, like Sir said, with experience. With experience also matters a lot. It's not that what we see here in Pondicherry, even people in Delhi may not see. So how can you have a guideline for that? So it has to evolve locally also. What we see in US and what they follow in US, we can't follow in India. So guidelines are broad ones are good. But yes, intricate details, we need not worry. So don't worry about what will happen if you put in YouTube. I think it should go because many people are of the thought that we can't go 100% with guidelines. We have to follow. That's what I wanted to say. Thank you.
Dr. Lakta, thank you for bailing me out and supporting me from Radhakrishna. But I can tell you that all what written is not all evidence based. I have all the articles to tell all these things. It is though it is all supports my things. But see, this is a talk. It's any pro con you will have as a for and against. I'm not really worried, but I just want to tell you because, like Radhakrishna said, the juniors hear this and then feel that protocol is not important. I think some people should take with the proper think properly in this, then only you can say what it is. So I think they should not blindly follow my talk. That's what it's important. You are all people who are all experts, they find yes or no with us. So that's why I was telling juniors should not listen to and say that Ramesh said don't follow protocols. I'm not telling don't follow protocols. Please
no
follow
one talk will influence people. They take from multiple things. So it's okay. Sorry, but I missed the initial part of the talk. I've just been there for the discussion. So.
No problem, no problem, no problem.
Thank you everyone for joining and making this session lively. And I'm sure we will go back and look at our own guidelines and protocols in a more critical way tomorrow. And like Dr. Pankaj Kundra said, some things are just have to be done. There is no two ways about it. There is no escaping it. Like he said, proper machine check and identification of drugs before injection. There are some things which are just no. And unfortunately, what we find in daily practices, these are the things which have been proven to be increasing patient safety and preventing never events. That is where we slip up and don't follow. Whereas random guidelines which are just there for convenience, sometimes people take it as gospel truth. In fact, there was even a comment in one of the WhatsApp groups that we should not bring religion. So it was just meant as just to give a twist to it. So thank you everyone for joining and for all the lively discussion. And we'll meet you again next week with another episode of Marvelous Medicine. Then take care and stay safe.
Thank you. Thank you very much. A very good night. Thank you, Dr. Ramesh.
Good night.
Thank you, Biju and Dr.